Hi everyone, it's your friend Doris Thecoder, and keeping in line with my promise, today's video is going to be for those reimbursement professionals. So this will help you if you're a biller, collector, work in the front desk, could also help you from a coding in. The example I have here is a Medicaid example, but it can apply to Medicare and or Medicaid. So if you are processing EOBs or remittance advices, you see something like what you see on this top screen here, right? Where you've got this is a snip from an ERA, an electronic remittance advice. This could also be referred to as an EOB or explanation of benefits. It's basically a document or statement sent from the insurance company to the provider service with line level detail about how they processed each charge. So in this case, the provider used a 99214, a 62323, and a J1100, which is a medication that the provider injected. Now, this is a provider in the state of Illinois. So we got a different code, CO236 here, because it looks like it was probably billed without a modifier. So immediately they processed that and said not paying, and it's on with this other line. But then we got an OA-109 or other adjustment 109, and that's what we're going to talk about today. I'm going to help you understand why you're getting this kind of denial and what you can do in your front desk or administrative processes to cure that. So you might think, how do I even get this denial? We verified benefits. It said the patient was eligible. We billed the insurance the patient gave us, and the payer denied it. It doesn't make sense. Anytime you verify benefits, insurance companies will tell you that verification of benefits is not a guarantee of payment. And although that is sometimes true, this is not necessarily what happened in this scenario. So you have to understand, and I'm going to put in the description box for you links to both the Medicare and Medicaid site. I'll start at that high level. I could do probably a whole thing on insurance, but it would be longer than I want this video to actually go. So I'll just give you an overview of the Medicare and Medicaid programs. Medicare and Medicaid are both federal, well, let's break it down by payer. So Medicare is a federal program. So when you look at your paycheck, you have a deduction referred to as FICA, FICA, the Federal Insurance Contribution Act. That is a combination of both the Medicare tax and the Social Security tax. So if you are a person who the golden age, you reach that golden age of 65, you become eligible, as of today's date, you become eligible for Medicare benefits because of age. But you could have patients, and this is really why you see the FICA deductions now, who are not 65 that have Medicare. These are patients who either have medical conditions that qualifies them for Medicare, or they have a disability that qualifies them for Medicare. In order to qualify for Medicare, however, you have to pay into Medicare for 10 consecutive years, or 10 years. If you don't pay into Medicare for 10 years, and depending on the amount that you pay, that determines like the Social Security disability check size you might get. If you don't, then you would not be eligible for Medicare, but you may have to go to another federally supported or funded program, Medicaid. When you are getting those FICA deductions, it largely funds your Medicare. State level income or state level revenue funds the Medicaid program. And this is why, if you're a Medicare patient, you can take that card and that number to any provider in any of the 50 states, and it's the same number, and you don't really have as much red tape to go through to access care. However, if you are a provider or a patient who goes from one state to another and you have Medicaid, there are very few conditions or circumstances under which your plan will cover you out of state, because the funds that fund your plan are at the state level. So money that I pay in Florida, although if I pay, my FICA taxes, that pays into Medicare, but it doesn't fund Illinois, right? And and Illinois funds don't fund Florida. That is set at a state level. So why does that become important? It's important that you understand what those basic programs are, and understand that Medicaid will never pay first to anyone. Following the hierarchy, right? Medicare will also only pay first to Medicaid. And in some circumstances, if a patient is like the working age, there's a few criteria. So you can definitively say that Medicaid is always the payer of last resort. They will always pay in a secondary position if any other person is payer is in the mix with responsibility for claims payment. Medicare may or may not, just kind of depending on the circumstance of the particular patient for their healthcare services. Both of these also exclude third-party liability. So if you have a person who's injured in a car accident or workers' comp, Medicare and neither Medicare nor Medicaid will pay those because that's under a third-party liability. They have auto insurance. Their auto insurance needs to cover and exhaust before you bill anything to Medicare and Medicaid. So once it's exhausted as far as auto insurance is concerned, then the Medicaid would become primary if that's all they had, or the Medicare would become primary if that's already all they had. If a patient had the combination Medi-Medi, that is Medicare and Medicaid, then Medicare would be primary because remember the rule, Medicaid is always the payer of last resort. So where this gets tricky, right, with that basic understanding, where that gets tricky is you might get a denial like what you see here. And the one I'm really looking at is this OA-109. OA-109 reads, not payable by this contractor. Please bill the proper contractor, or something to that effect. I'm paraphrasing because I'm sure that's not the total definition, but it's not payable by this payer. So now when we verified insurance coverage, we got that nice green banner off of Validity or through your practice management system, and it says Illinois Medicaid coverage is active coverage. You have to understand that when a patient has Medicare or Medicaid, they meet that criteria for Medicare or Medicaid. So when you're getting the active coverage back, first, we should have the right card and information on file, but especially when dealing with the elderly population and based on what your patient mix is with regard to some of the conditions, these patients really may not know what insurance they have. I thought that sounded kind of crazy, but really, no, there are patients who really don't understand this insurance thing, so they don't know what they have. So because the Medicaid information was entered, it verified and they came back and said, yes, they're active. Chances are if you got an OA-109 and you got active coverage, nothing changed from the time you rendered the service to now, because they indicated the service date was 2/26, especially in a federal program and in a government program, right? They indicated the service date was 2/26/01. So this is what they were active for. But when they verified the benefits, the payer will actually tell you when there is another payer. Here's the thing, and you can think about it like replacement. Medicare, a patient continues to pay Medicare their premium when they have Medicare, for example, right? And Medicare will pay those funds sometimes to a managed care plan. Same thing with Medicaid. They have to meet Medicaid criteria. Medicaid would enroll that patient in a managed care Medicaid plan. So in order for them to be eligible for the managed care plan, be it Medicare or Medicaid, they must continue to meet the criteria for Medicare if it's a Medicare Advantage plan, or Medicaid in the case of a Medicaid Advantage plan. So when you verify your coverage, they are going to tell you it's active because the patient has met that criteria. 65 again is the golden age for Medicare, but again, it could be a patient who has paid into the program for at least 10 years and has become disabled before reaching the age of 65. If a patient hasn't paid into Medicare, or they haven't worked long enough to have deductions for 10 years before becoming disabled, then Medicaid may be their only option because they've not paid into the program long enough to qualify for Medicare benefits. So that becomes important because then you'll have your Medicare patients who are under 65, but each of the eligibility responses, because they have to meet either Medicare or Medicaid criteria, is going to come back active, and that is their way of letting you know that they continue to meet the Medicare or Medicaid criteria. But what they also tell you on those cases is that there is other coverage. Okay, and that other coverage that they're telling you is the coverage that you should bill. Now, the really helpful part that a lot of the government plans like Medicare and Medicaid will communicate back to you is who that plan is, right? So this particular patient that we try to bill Illinois Medicaid for, Illinois Medicaid said, yeah, they're active, they meet the criteria for Medicaid, but we have a managed care plan that's handling this patient, and it's Blue Cross and Blue Shield MMCP plan, and you can call them at this number. So they really give you almost all the info you need, but what you don't see that they give you here is the ID number. So when this comes back and you verify, your front desk people should be paying attention to the other coverage information field, and they need to be asking the patient for, in this case, the Blue Cross and Blue Shield Medicaid plan card. Okay. And if they are not clear, then they need to call the plan, because Medicaid is very clearly having them enrolled as of that date of service in that plan. If necessary, the patient can call and get their number if they need it. Some of the plans have sites where you can enter the patient's date of birth and their last name or their social or their Medicaid number or Medicare number, and it will give you the number. A lot of them don't. You actually have to have that number, or you have to have the patient call and get the card to figure out what the number is. So this is no value for me if I know that the patient has this plan and I don't have that info, because if I just got the denial that said OA-109, I still don't know where to bill it. So when you see these kind of things, you can track your CAS codes. You can actually educate your front desk on what these things mean, because if they're getting the green, they could see active and just keep moving, not realizing that you're being directed to another payer. So for my reimbursement people, this will help you cure and rectify the denials for OA-109 that come back not payable by this contractor. Please bill the proper payer. I hope you found this video helpful, and you know what I always say, like it if you do. Subscribe so you can follow me and know when I post, and if you think this video is helpful and you know someone else who might find it helpful, feel free to share it. Until the next video, take care, and I'll see you in the next one.